Our next panelist is Natalie Mehra. She's the director of the Ontario Health Coalition, an organization encompassing more than 70 local chapters and more than 400 organizations across Ontario. She has spent the last decade building the Health Coalition into the largest and broadest public interest group on health care in Ontario. Natalie has been a board member for a number of human rights, arts, health, advocacy, disability, and women's organizations, and currently sits on the board of the Canadian Health Coalition. Prior to joining the Health Coalition, Natalie served as the executive director of the Epilepsy Association in Kingston and Brockville. She has extensive experience as a community organizer, dedicated to building and coordinating democratic citizens' engagement in issues related to poverty and equality, human rights, social justice, and health. Natalie has authored numerous published reports, essays, and articles on various sectors and issues in our public health system on nonprofit governance, poverty, disability, health, and politics. She has spearheaded several national campaigns to protect the public health care system from privatization. And please welcome Natalie Mehra.
So I'm going to start with a joke which comes from Pat Armstrong. I know some of you have heard it before, but it's very fitting for this. I'll explain why after. So there's this guy, and he works at a construction site. And every day at the end of work, he wheels out a wheelbarrow covered in a tarp. And every day his supervisors go through the site, and they try and figure out what is it that he's taking out in this wheelbarrow covered in a tarp. And they search the site from top to bottom, and every day they can't find anything missing. And they do this every day for a week, and then they do it for another week. And finally, at the end of 2 weeks, they say to him, look, we're not going to fire you, we're not going to call the police, but you're driving us crazy. What is it that you're taking out of the construction site every day in your wheelbarrow covered with a tarp? And he says, wheelbarrows. And Pat uses this to describe the way that our healthcare system is kind of being stolen from underneath us without people really realizing it. It's that, death by 1,000 cuts that people talk about, or privatization by stealth. And home care actually is kind of the living example of this. Pat also, I think quite brilliantly, describes how privatization works. She kind of breaks it down for people, and she says privatization is a bunch of changes. And can any of you tell me what some of those, what does privatization mean? What changes when you privatize? Delisting. So it's a privatization of who pays for the service. Whether you pool your money and your taxes, as in we're all in this together, and you transfer it out based on need, not based on ability to pay, right? So it's a transfer of income, it's pooling our resources and pooling our risk. What else is privatization? Downgrading of salaries, and Pat describes it as the movement of care work from paid caregivers to voluntary caregivers, often women in the home. What else is privatization? Mike? Right, so it's the transfer of ownership from public and not-for-profit to private and for-profit, and the movement of the control of services out of the democratic realm into private hands. She also says that it is the transfer of responsibility for each other, from the collective to the individual, from we're all in this together to take care of yourselves and your own. And she says it's the adoption of private sector modalities, kind of turning patients into widgets, if you will, within the public service itself. And in home care, we've seen actually all of these things in Ontario, and perhaps to a more extreme level than other provinces, but certainly other provinces have sort of come along down the road that Ontario has forged, unfortunately. And I believe that the context is necessary because it holds some lessons for us in organizing now. So I'll very quickly run through the context in Ontario. In Ontario under the Harris government. So starting in 1995, this is when we started to see the really big tax cuts. I mean, if you want to see, trace back to the sort of real start of the change of the tax system to benefit the rich at the expense of everyone else, you'd have to go to Mulroney. But in Ontario, really it started with the Harris government. And under the Harris government, they cut 10,000 critical, acute, and chronic care hospital beds. And with that, they tried to take $1 billion out of the hospital system. They replaced those with 20,000 long-term care beds, and most of which were given to private for-profit companies, and with what they said was an expansion of home care. In the end, they did increase home care in terms of funding, but they downloaded tons of clients into home care, patients into home care, and home care funding has never kept up now with the downloading of patients over the last 20 years in Ontario. And so they brought in competitive bidding in home care. And this is the model that they really favored to extend privatization throughout the system. So home care in Ontario for 100 years was provided by the Victorian Order of Nurses, and then the Red Cross and the VHA not-for-profit agencies. For a long time it was charitable. There was some municipal funding for it for a period, but it was kind of ad hoc. There was never really a full home care system. The dream of creating a full long-term care system in the home really came to a head under the NDP government, who consulted widely on how to create a full home care system out of the kind of ad hoc system that existed in Ontario, and ultimately came up with what they called the Long-Term Care Act. They passed it and then lost office, so they never actually promulgated regulations under that act, and the act never was really put into effect. Too bad, because if they'd had the guts to do it a little bit earlier, we would not have the home care system that we have now in Ontario. So the Harris government got in, made all the hospital cuts, privatized long-term care, privatized home care very significantly. And what they did was very clearly cap the entitlement to care. So within the home care system, they brought in a regulation that very strictly limited the amount of home care that you would be able to get in a very overt attempt to undermine the scope of the Canada Health Act, right? Move the patients out of hospital where they have the right to full services covered publicly, move them into home care, privatize the ownership of it, and then cap the amount that is actually paid for publicly, forcing people to pay out of pocket to subsidize themselves privately. And this has happened in every round of hospital cuts ever since in Ontario, and hospital cuts have continued. In fact, since 1980, 30,000 hospital beds have been closed in this province, 18,500 of them since 1990. And as I said, care in the community has never kept pace with the hospital cuts. Currently in Ontario, there are 23,000 people on wait lists for nursing home beds, 30,000 if you include the people, 29,900 if you include the people waiting in hospitals for a bed at a nursing home. According to the provincial auditor, there are 10,000 people on wait lists for home care across Ontario. And I say these numbers just to show you that I'm not making it up when I say that as they cut the hospital services, the entitlement to care disappears. And people are left much more to themselves and forced in long-term care homes to wait for care for extended periods of time. And then when they do get it, they won't bring in a minimum care standard or long-term care to ensure that they have enough care, neither in the facilities nor in home care. And so people have to pay out of pocket to supplement. The bringing in of competitive bidding in home care in Ontario really did change the way that home care was provided. It changed the practice of nurses and personal support workers, as well as ushering in a change in ownership in the sector. In order to compete, in order to bid on home care services, you have to create a measurable unit of home care services. And so they created an hour-long visit. They gave strict time limits to the workers to tell them that they had to provide baths within a very short period of time. They had to get the patient or the client in and out of the bathtub. They had to do this, that, and the other so they could get on to the next visit super fast, so that they could compete against each other for contracts, which really are based on the lowest price, despite all rhetoric to the contrary. In fact, there really is no measure of quality in home care. It's hard to do because, of course, if your company doesn't provide the service, nobody's going to complain about you. There will be complaints about the company that does provide the service, of course, but it's hard to measure, you know, how they would measure up against a different company because only one company can provide the service in your house at any given point in time. Moreover, there is no direct supervision in a person's home. And so what happened in Ontario, despite all the nonsense about competition creating quality, in fact, companies that didn't exist at all, had no employees whatsoever in the area, were able to underbid other companies and win contracts. Their goal was to hire all of the laid off workers of the previous company. And in fact, when we talked to the heads of some of the not-for-profit agencies, they refer to it as renting workers. In fact, there is no surplus of labor not anywhere in the healthcare system, certainly not in home care. And so the goal of the companies that win the contracts is simply to hire on all of the laid off workers from the previous company. It absolutely destroys employment conditions. It deunionizes the sector. It's done so, you know, very quickly, frankly, in Ontario. Home care is, compared to hospitals or long-term care, very, very low level of unionization, very hard to unionize. It destroys the working conditions. Every time your company loses a contract, you lose your seniority, you lose your accumulated vacation, you lose all of the benefits that you had before, and you have to start again. And so to be a nurse or a personal support worker in the home care sector under competitive bidding is a very, very unattractive option. It's hard to create a career in that scenario. In fact, the turnover in home care in Ontario has, in the years of competitive bidding, ranged as high as 78%, unheard of levels of staff turnover, and a huge waste of money as new staff have to be trained and then routinely retrained and so on and so forth. And all of this for a system that actually doesn't breed competition. At the end of the day, now a decade and a half into competitive bidding in Ontario, we have a smaller number of large companies controlling more of the contracts than we ever have. So the market has consolidated into the hands of the largest for-profit and not-for-profit companies at the expense of the community-based not-for-profit agencies. And the reason for that is that little companies can't, or the little not-for-profits can't outbid the large ones. The large ones can take a loss for the first two contracts just to get their foot into the market and expand so they can speculate on their growth. The little ones can't do that. They can hire consultants in the large ones to bid across a whole swath of contracts going out and therefore learn how to win the contracts. The small ones can't do that. And so in Ontario, what's happened is really the death of the community-based home care system and a takeover by the large multinational, often companies. In addition to the instability for the workers, of course, there is the instability for the clients. And accompanying the extraordinary levels of staff turnover brought about by competitive bidding is a problem in actually attracting workers and very, very severe staffing shortages across the home care system, to the point that wait lists for physiotherapy and home care, for example, are mainly attributable not to a lack of funding, but to a lack of workers, a lack of physiotherapists to provide those services. The for-profit companies have had a very deleterious impact. Not only do they have a higher markup, Jane Aronson, a professor at McGill University, compared the contract prices between the Victorian Order of Nurses and the for-profits in Hamilton and found, demonstrated that the for-profits had a higher markup. And they made that difference, the room for their profit, out of reducing the wages and working conditions of the workers. In home care in Ontario, you can tell the difference between the for-profits and the not-for-profits. The for-profits do not provide regular, permanent, full-time employment. Their workers are, the vast majority of them are casual, temporary workers. They have lobbied against extending basic employment standards to home care workers in Ontario, personal support workers who don't enjoy basic employment standards like the right to severance or notice of termination that are in the Employment Standards Act. And they have and continue to lobby against extending those standards to them. And they've lobbied for more two-tier home care because, of course, it gives them another revenue stream if you can pay out of pocket for home care as well as bill, the public health care system. You have two revenue streams from which to take money. And so if you go online, you can find a position statement of the for-profit lobby group in Ontario all about how private health care has a viable and important place in the market. They have also driven up administrative costs dramatically. In Ontario now, $500 million a year is spent on administration in the CCACs alone. There are 4 tiers of administration. There are more than 700 provider agencies across Ontario, a lot of those branch plans. But all of those have to have their own administrations, their own computer systems, then they have to send out their people to travel. You might have a home care worker from one company travel 100 kilometers out from the main CAC office, and a home care worker from another agency travel the same distance and be providing services to clients right next door to each other, and they won't know it. The reason for that is that in order to maintain competition, you have to maintain 7 or 8 or 10 companies in an area so that they can bid against each other. And so you have to pay for all of the duplication and all of that stuff that is required to create the market for competition. So Ontario's home care system now has 4 tiers of administration before any money reaches a frontline nurse or personal support worker. It has a diminishing level of entitlement to care, as I talked about. It has extraordinary wait lists. It has the poorest working conditions of any sector in the healthcare system. And for those people who dreamed of creating a long-term care system in the home, that dream has never been further away. The selling of home care as the cheap alternative to hospitals has meant that governments of every stripe now have pursued policies of downloading patients from hospitals into home care. They've taken up all of the home care budgets, and the seniors who would have been seeking home care as a place to as a funding mechanism to age and support mechanism to age in place have been displaced off of the wait lists for home care by the acute care patients. Ontario no longer has any kind of plan to bring in a holistic system to provide the supports for people to age at home. And in fact, if there's anywhere that we're going, it's the opposite direction. It's the shrinking of the scope of public Medicare to only cover acute care services and to really lop off coverage for all of the longer term care services, whether they be in hospitals, long-term care homes, or in home care. So I just want to end with a couple of notes. For those of you from Ontario, the current context is extremely grim, and I don't think people really understand it. We have a $14 billion provincial deficit. It looks like it's going to go up to $20 billion. We have, according to the provincial auditor's report in June, the plan is that healthcare funding for next year is going to be dramatically less than in previous years. And so we're looking at, according to the provincial auditor's report from June, they're going to have to cut $1 billion out of hospitals on top of a wage freeze this year and next year, over the next 2 years. The increases for long-term care have been cut in half. The increases for home care have been cut into a third. And so all of those cuts from hospitals will not be offset by increasing care in the community. And like across the country, as that care is moved out of hospitals, we really are losing the principles of the Canada Health Act for those services. And like in the rest of the country, Medicare has expanded in certain ways. We've vastly increased the number of elective surgeries we do, hips and knees, cataracts, MRIs, and other diagnostics, cancer care, cardiac care over the last few years. But we have shrunk services also in a very significant way, particularly services for those with chronic illnesses and for seniors who require longer-term care. And that shrinkage in the scope of services, so the cuts to access to services, are happening in hospitals, in long-term care homes, and in home care. And so any fight for home care needs to take place within that context. The time for competition between those who advocate for home care and those who advocate for hospital care is long over. They have cut the hospital beds. We now have the lowest of any industrialized country in the world, practically. We're fourth from the bottom now of the OECD. All of Canada is extremely low in terms of hospital beds. We've done those cuts. We've supposedly moved the care to the community. The fight is now to maintain the existing hospital services and advocate for additional services in the community, because the cuts in hospitals have never been offset by increases in services in the community. At the national level, we have not moved forward at all on home care in the last 10 years. The Romano report recommended short-term home care, that is post-acute home care for mental health and for post-acute and palliative care. That was adopted in the 2003 Health Accord and made it into the 2004 10-year health plan that Paul Martin put together. There was $500 million over 5 years, 3 years, for paltry kind of funding for it across the country. It was unenforceable, and it's a scope of services that is less than many provinces already provide in home care. Coming up will be the negotiations for the National Health Accord, which will either end in 2014 or will force the Harper government to renew it. It shouldn't be any shock to know that the Harper government is not keen to renew that federal health accord, but it is crucial, and we need to get our act together to determine what is it that we're advocating for regarding home and long-term care to be in that accord, and we need to do it soon because the first meetings start at the end of November. So I think it's very timely that you have this conference. I applaud it, and I hope that what you come up with will help to instruct the health coalitions of the rest of the movement on a path to move forward. I just want to end by saying, you know, we live in very difficult times, there's no question. The context is very grim, but it is possible, even in these times, to win. I think the example from Manitoba of the lawn sign campaign, the tremendous campaigning you did on home care, is a great example for the rest of the country. And the type of campaign, let's face it, that we're going to have to do to make any policy paper that you come up with a reality, that the struggle that we have with Harper is going to be a power struggle. We forced him into the 2-year 6% escalator promised during the election. That was an amazing feat, actually. But we're going to have to force him into the gains that we want to make at this point. And it's going to take some major campaigning. In Ontario, huge protests, including one of 3,000 or more people in Hamilton alone, when the VON lost the contract, have forced two, not one, but two moratoriums or moratoria on competitive bidding. We've stopped it twice. We haven't killed it, but we've stopped it twice. That's a pretty major thing to do in the face of a host of now entrenched for a decade multinational private healthcare companies. So we can win in this fight, and I guess I'll leave with the words of Bob White. Sometimes it's not the strength of the argument that matters, it's the strength behind the argument, and that's you. Thanks.